Okay, okay.
Great.
Yeah, thank you very much. So now that we've sort of went through the agenda, I want to talk about a little bit of background on this effort. So cancer centers are required to formally define their regions that they serve. HCI is a designated cancer center for Montana, Idaho, Wyoming, Utah, and Nevada. So, I mean, and while we have sort of served patients from all of these states, we have made a formal commitment in 2021 to be the designated cancer center for this 5-state area. So that's why we make sure that in all of these webinars, we're very intentional with the presenters that we include. We make sure that we have representation from these states just to sort of increase collaboration and ensure that you are receiving information from diverse voices and expertise across the region. Next slide, please. So the Office of Community Outreach and Engagement is the convener of this effort and of the Mountain West Cancer Collaborative. We work really closely with a diverse range of partners, which includes comprehensive cancer centers, cancer control programs, cancer coalitions, different health systems. But really what our mission is as the Office of Community Outreach and Engagement is to be able to improve awareness and understanding of cancer risk factors, prevention, screening, treatment, and even clinical trial enrollment. So we engage with communities in a variety of different ways, but the Mountain West Cancer Collaborative is really a great platform for us to just provide this opportunity for information sharing. If you'll show the next slide, Jill, I have a QR code that if you haven't joined our collaborative already, if you received this information forwarded from a colleague, I encourage you to join. You'll be able to receive monthly newsletters, quarterly webinar opportunities, and other relevant information that we share out through this listserv. So I'll give you just a second to be able to pull up the camera on your phone and sign up through this QR code. And Jill, you can go ahead and go to the next slide. So the objectives for today's presentation are to be able to explore the role and impact of low-dose CT scans and innovative programs such as voucher systems that help us improve access to early lung cancer detection in our underserved populations. We want to be able to highlight the impactful radon education efforts that are happening and discuss common challenges and opportunities for regional collaboration when it comes to lung cancer prevention and screening. But really all of these presentations today, while they feel like very separate topics, they are connected by a common goal, and that is to reduce the disparities in lung cancer prevention and care. And each of these programs play a vital role in that. If you'll go to my next slide, Jill, I'm going to take a moment to introduce our first speaker, Diane Clausen. So Diane has over 30 years of experience in radiology and is nationally registered in multiple modalities, including X-ray, mammography, MRI, CT, and ultrasound for OBGYN, abdomen, and vascular. She lives in Winnemucca, Nevada, and has for the last 17 years and has worked for Humboldt General Hospital during that time. As a 3-year breast cancer survivor, she brings a personal perspective to her work. She has a husband, 6 children, and 3 grandchildren. One of her latest accomplishments is building a low-dose CT lung cancer screening program at Humboldt General Hospital, which has enabled the Nevada Cancer Coalition to develop a toolkit on now used across the state of Nevada. Her contributions were recognized with the Nevada Unsung Hero Award. Diane, thank you so much for being here, and I'm going to turn the time over to you.
Thank you. Can you hear me?
Yes, Diane, we can hear you.
Okay. So low-dose lung cancer screening is low-dose computed tomography, LDCT. A low-dose CT scan is a scan that is pre-programmed to be low-dose, 3 milligrams, performed for early detection of lung cancer. Expanding coverage broadens access for lung cancer screening to at-risk populations. That comes from CMS Chief Medical Officer, Dr. Lee Fleischer. Next slide. What is an LDCT? Much like a mammogram or a colonoscopy, lung cancer screening is a regular preventative health check. If screening detects lung cancer at an early stage when it is small and before it has spread, it's more likely to be treated successfully, significantly increasing the patient's 5-year survival rate. Next slide. A low-dose CT scan is the only screening method recommended for at-risk patients. The LDCT machine takes a 3D picture of your lungs, showing more detail than a standard chest X-ray. LDCT scans use 75% less radiation than a regular CT scan and does not require needles. As you can see, the two images up top, on the left is a standard chest X-ray, and on the right would be one of the images from a low-dose lung cancer screening. The arrows are pointing to the same tumor in the lungs. Next slide. Who should be screened for lung cancer? LDCT screening is only recommended for individuals at risk for lung cancer. You are only considered at risk and eligible for screening if you are 50 to 80 years old, are currently smoking or have quit within the last 15 years, have a smoking history of 20 packs per year or more. We're trying to change this in Nevada due to the high level of smoking in casinos. The casino workers receive a lot of secondhand smoke and are at high risk also. Next slide. What happens before, during, and after a lung cancer screening? Before your screening, you will meet with your provider to discuss the benefits and risks of screening. If you decide on screening, your provider will order the screening and refer you to a location that offers LDCT. Your provider's office may make an appointment for you, or you may need to contact the screening location to set up your appointment. Next slide. During your screening, you lie on your back on a table while pictures are taken of your lungs. You should not need to change your clothes as long as they do not contain metal. No medicines or needles are required for the procedure. Next slide. A specialist will read your scan, and someone from the screening location or your healthcare team will meet you to discuss the results. And November is Lung Cancer Awareness Month, as we probably all know. Next slide. Common risk factors for lung cancer include smoking, exposure to secondhand smoke, exposure to radon gas, exposure to asbestos, arsenic, and other carcinogens, having a personal or family history of lung cancer. Many facilities have a cash pay rate if your insurance does not authorize it, an LDCT. So if you have exposure to these risk factors, there's an option to still have an LDCT as long as you have a provider's order. So just because you don't qualify for the eligibility, it doesn't mean you can't have one. Next slide. What should I ask my healthcare provider about lung cancer screening? Is lung cancer screening for me? How do I know if my insurance covers LDCT screening? What are the benefits and risks of LDCT screening? How will I get my results of the LDCT scan? And what tools are available to help me quit smoking? Next slide. Lung cancer is the leading cause of cancer deaths in the U.S., accounting for about 1 in 5 cancer deaths. It is the leading cause of cancer deaths in men and women. Early detection saves lives. Lung cancer screening could decrease the death rate for lung cancer by 20%. In the table to the right, you can see lung cancer is attributed to double the death rate of all other cancers. Next slide. Statistics in Nevada for smoking. Nevada is 14th in the nation for lung cancer incidence at 53.3 per 100,000. Nevada is 50th in the U.S. for obtaining lung cancer screenings. Smoking rates are 15.5%. This is all for adults, except for in high school, it's 4.8%. And vaping rates in high school are 18.8%. Winnemucca, we're at 28.8% for smoking, which is much higher than the state smoking rates. Next slide. The statistics in Utah. Utah is the lowest in the nation for lung cancer incidence at 26.6 per 100,000. Utah is 45th in the U.S. for obtaining lung cancer screenings. The smoking rates are 6.9%. Smoking rates in high school are 1.2%, and vaping rates in high school are 9.7%. Next slide. Statistics in the U.S. The national rate of new lung cancer cases is 56.7 per 100,000 people. Only 5% of those diagnosed with lung cancer were screened with LDCT. Smoking rates nationally are 20%. Smoking rates in high schools nationally are 1.9%, and vaping rates in high schools nationally are 10%. Next slide. So the statistics in different populations across the U.S. American Indian, Alaska Native adult smoking rate is 21.9%. Non-Hispanic white adult smoking rate is 16.6%. Hispanic Latino adults in the U.S. smoking rate is 16.2%. African American adult smoking rates are 11.8%. Pacific Islander adults in the U.S. smoking rate is 10%. Asian American adult smoking rate is 7%. And next slide. So this is statistics throughout the Mountain West. As you can see by the graph, Nevada has the highest smoking rates. Nevada and Wyoming are equal, actually, with 15.5%. And Wyoming has 20% of high schoolers smoking. Then Idaho has the highest rate for lung cancer, or low-dose lung cancer screening. Next slide. CMS regulations revised eligibility for low-dose lung cancer screening February 2022, which launched a countrywide push for low-dose lung cancer screening. One of the things they changed was patient eligibility, counseling and shared decision-making provider visit, the imaging facility eligibility, the radiologist eligibility, and the American College of Radiology National Data Registry. This is not a requirement by CMS, but it is a way that we're gathering our statistics, and I'll go over some of those statistics that the ACR is gathering in a future slide. Next slide. So patient eligibility, age 50 to 80, must have a counseling and shared decision-making consult with a provider or auxiliary personnel. They must be asymptomatic, have a smoking history of greater than or equal to 20 pack years, are currently smoking or have quit within the last 15 years. As far as the pack years go, for instance, if a person started smoking at age 15 and they smoked 2 packs per day, they're age 60, that would equal 90 pack years. Next slide. The reading radiologist eligibility criteria. The reading radiologist must have board certification or board eligibility with the American Board of Radiology or an equivalent organization. Next slide. Oops, I'm missing some. Radiology imaging facility eligibility criteria. The reading must be furnished in a radiology imaging facility that utilizes a standardized lung nodule identification, classification, and reporting system provided by, 2 examples are the ACR, the American College of Radiology, or the Fleischner Society. Next slide. So this is an example of the ACR classification system. And this is verbiage that has to be put in the report from the CT scan. The first one is incomplete, which would be a category 0 is how they label it. That means there's nothing questionable. The second one is negative. No nodules and definitely benign nodules would be a category 1. Benign appearance or behavior. Nodules with a very low likelihood of becoming a clinically active cancer due to size or lack of growth would be a category 2. Probably benign. Probably benign findings, short-term follow-up suggested, includes nodules with a low likelihood of becoming a clinically active cancer. That's a category 3. So that if they see something questionable, but they're pretty sure it's benign, sometimes they'll still order a short-term follow-up, maybe to have another scan in 3 months to see if there's any changes. And then a suspicious finding for which additional diagnostic testing and or tissue sampling is recommended. This is usually they'll recommend a biopsy of the nodule that they're seeing. Next slide.
Jill, I think there were just some glitches in SharePoint, so if you'll just go to the next one.
Okay. So for prior authorizations, coding seems to be the biggest roadblock that we reached here at HGH. If the codes are incorrect, they don't get paid. And most facilities, if they're not getting paid, they're not going to do the exams or offer them. So for prior authorizations with insurance, Medicare Advantage and commercial insurance typically does require pre-authorization for low-dose lung cancer screening. Not required for traditional Medicare. Nevada Medicaid does not require pre-authorization. And the patient must have had a shared decision-making consultation with a provider or auxiliary personnel, visit code G0296 before the LDCT. There's generally no copay, and the recommended ICD-10 codes, which would come from the provider, are Z87.891 and F17.210. Next slide. The problems and pitfalls of an LDCT program. The resistance to change. So getting past the old regulations and eligibility. With my radiologist, I had to provide a lot of documentation from CMS for him to trust that the regulations had changed. Coding correctly for reimbursement, which I said before, if they're not getting paid due to coding reasons, they're not going to offer the exams. Getting past the stigma of unnecessary radiation. Less than 3 milligrams per scan results outweigh the risk about the same as an average person gets in a year from environmental factors. Recommended low-dose CT protocol can be downloaded from the ACR website. So they do have a protocol that we actually program into our CT scanners in order for them to be low dose, the lower dose. Next slide. Provider and patient education. We just need to get the word out there. Next slide. So informative pamphlets. So we have these, we've given these to all of our providers. We have them laying around the hospital. We give them away at our health fairs. Just anybody who will take a pamphlet, that's who we will give it to them. Next slide. Attending community health fairs. Last year we had the Nevada Cancer Coalition actually brought their inflatable lungs. And that really got a lot of attention for our lung cancer screening program. Next slide. And provider and patient education, visit tribal health clinics and functions. I actually went out to our tribal health clinic, which is about 60 miles out of Winnemucca, and talked to their provider there, making sure she knew that we offered the services. And next slide. Patient education, attend churches and or cultural functions. So we have a pretty high rate of smokers in the Hispanic community, and I had a hard time reaching out and getting them to come in for the CT scanning, for the CT scans. So I actually realized I went to church with a lot of them, and I started going to more functions and handing out our flyers. And so we got a bigger population of the Hispanics to come in for those screenings. Next slide. And then, of course, social media campaigns. The American Cancer Society, here's a poster, "Lung cancer won't quit even if you did." Thanks to a new scan, lung cancer can be detected early when it's more curable. If you smoked, get scanned. Talk to your doctor or visit savebythescan.org. Next slide. And that's it.
Great, thank you so much, Diane. It's my pleasure to introduce our next speaker with us today. I have the pleasure of working with Lynette frequently here. So Lynette Phillips is the manager of community cancer screening at Huntsman Cancer Institute. She's responsible for the first mobile cancer screening program, as well as all of the developments of protocols and procedures as it comes to bringing the state of Utah state-of-the-art cancer screenings, follow-up, diagnostic procedures, and cancer treatment at community clinics. So Lynette, it's my pleasure to turn the time over to you.
Thank you so much, Allison. And Diane, thank you. That was amazing information. I hope to not duplicate, just add a little bit of additional information from Huntsman's point of view. So, as we all know, lung cancer, the leading cause of cancer-related mortality, and that we have expanded to this we made a formalized commitment to the Mountain West in 2021 that we would help with cancer screenings, awareness, and reducing the cancer incidence in this large 17% of the landmass of the United States area that we have. And we are so grateful and humbled to be able to do this and to help the community, that we all have such a strong passion for this. Next slide, please. So obviously the data has shown effectiveness of why, how lung cancer screening, low-dose CTs, can help detect earliest stages of lung cancer when it's so much easier to treat. And we have minimally invasive technology that we can go in and remove some of the smaller tumors without even having to have, full open chest surgery. So there's a lot of great advancements medically. But still, with this death rate and the almost over 125,000 people estimated to die this year just from lung cancer alone, there's more that we need to do. Next, please. So when we did formalize our commitment to this larger Mountain West area, we noticed one thing very much in common, and that is that all 5 of these states that we are helping with all different cancer incidents and ways to try to get patients in for diagnostics, and that is that every one of these states is in the bottom of screening for all different cancers. And so there's a lot of work for us to do. So as we know, there is a 20% relative reduction in lung cancer mortality from this large national lung screening trial, and also a 24% in this Nelson randomized controlled trial. And that's larger than we even see in mammography. Now, mammography has had great uptake because there's been so much awareness of it. Everything was pink for a very long time. And a lot of women know that they need to go annually and get their mammogram. Now, we do need to keep increasing those rates, but low-dose chest CT is a faster, more effective detection tool. Yet why are our rates so low in this area that we serve? Next, please. We did dig a little bit into some of the checking into our marginalized communities, our underserved communities, and have found that there are statistically significant differences in the death rate for lung cancer patients in our Black and Pacific Islander populations. This is Utah only, but we know that underserved, underscreened populations tend to have higher incidence and higher death rates across all cancers. So we do need to target some specific interventions and tailor some of our messages towards different populations. Next, please. So, as we mentioned, lung cancer screening is recommended by the USPSTF and is covered under the Affordable Care Act for people who are eligible at low, no cost, but our screening rates do remain low. So all of the brilliant people at Huntsman Cancer, and I am so lucky to be working with them, have been working on multiple different modalities to try to figure out how we can make sustainable differences. So next, please. Here's just a few of the things that this giant team of people have put together. So between public health, healthcare, research, and advocacy, Huntsman has worked on multiple different interventions across our area that we serve, including a lot of different education materials, targeting not only the patients, which we need to get that patient to go talk to their provider, that provider to understand how important lung cancer screening is and get that patient scheduled for a low-dose CT at an imaging facility. And from there, if they need treatment, get them into treatment. That whole little chain of events that needs to happen takes multiple interventions, community, patient, and provider. And if a provider has graduated from medical school in like beyond the last 15 years, they didn't even learn about lung cancer screening since it's only been around since 2013 that it's been recommended. So there's a lot of education going all around that we need to work on, including the very rural and frontier providers who are trying to do everything that they can. And we know that primary care providers are so overwhelmed and they have so many things on their plate. So we're trying to make things as provider friendly as possible. We want to reduce that burden for them. We understand that they are absolutely swamped. Some of our researchers are working with different ways to enhance and pull out data from electronic health records. There are ways that we're working with the primary care associations to find better ways to comb through patient records and identify smoking history and patients that may have a good need to come in and get a low-dose CT. We also want to change the narrative. We know that smoking carries a lot of stigma around it, which is why in some areas like Utah, where I'm located, we do have lower incidence, but it is still the leading cause of cancer death here too. So people don't like to often talk about mistakes that they've made. And if you noticed in a couple slides previous to this, there's a patient talking to a provider looking at a low-dose chest CT. That's me. Mistakes were made in the 80s and 90s and continued on for a decade or two. But it's nice that I can advocate from this as also someone who has been through multiple low-dose cancer screening. And I do have a lung RADS too. I have a nodule that we are going to continue to watch. But it's nice to know also that I don't really have to worry about it. It's been stable for 3 years. So sharing that story with other people who may not look at me, they go, you work at a cancer center. Why would you be somebody who's getting a low-dose chest CT? I made mistakes. We all make mistakes. But we are here to help everybody get in for whatever cancer screening they need. We're also working on navigation networks, some transportation assistance that we are working on. And one thing I'm going to go really in depth on is how we are helping to reduce financial barriers and disparities for our low-income uninsured patients. Next, please. So one of the programs that we have put together to help with screenings, because we understand that there are a lot of patients who are uninsured and are low income and don't have any other resources. Now, we work closely with the National Breast and Cervical Cancer Early Detection System and their vouchers for breast and cervical screenings, which is amazing. But here in Utah, we didn't have options for anything besides that. So we had to come up with a way to help the same patient population who is at low income and uninsured to take charge of their health and have resources for them. So what we came up with, and we worked with primary care providers for almost a year before we launched this program. We worked with some very, very busy federally qualified health centers, and we made very simplified order sets so that they're not having to comb through 3 pages of radiology referral forms. And if it's asking if they're allergic to CT contrast or all of these other things that we didn't need to know for lung cancer screening specific. So we made simplified order sets, and we offer lung cancer screening and colonoscopy after a positive FIT test here at Huntsman Cancer. Unfortunately, these are restricted to Utah only residents at this time, but we are able to offer those. We also provide simple instructions on our webpage, and I'll go through the webpage with you. And also, we really want to advertise, bring awareness to the fact that there are those breast and cervical cancer vouchers that are available too. And if you have a patient who is eligible for one cancer screening, they're probably eligible for other cancer screenings too. So to put all of those into one easy to find place for our providers and our busy clinics. And then of course, the most important thing, patient focus, we wanted to reduce the structural barriers for them. We have spent the last few years working on very low literacy, simplified instructions. As Allison mentioned, I also oversee our mobile programs, which are mammography only at this time. We will be expanding in the future, but we run into the same thing there. We run into a lot of patients who were not afforded an education in their primary language. Primarily, we see a lot of patients who speak Spanish for the most part, but we've seen over 35 languages on our mobile, and a lot of them are illiterate in their primary language. So we've had to work on very low literacy, simplified instructions. For our voucher program, we spent a lot of time finding the right fit for a bilingual patient coordinator and navigator. And also, we're working with the primary care clinics, and they have navigators too. So their navigators work with our navigators to get the patients in, because we know those primary care clinics are the trusted home for patients. Next, please. So this is when you come to our cancer screening voucher program. This is the landing page that you will find us on. We have links to the email and our phone number. Now, our coordinator is, this is a part-time duty. She also runs a very, very busy high acuity clinic at our hospital. So she works on this about 50% of her time, but somebody, please leave a message is what I'm trying to say. But somebody will definitely get back with you. Next, please. Now, when you scroll down a little bit on our page, like I said, we're trying to make this as simple as possible for navigators and clinicians. So we show them exactly what the guidelines are, and we match them up to the National Breast and Cervical Cancer Early Detection Program guidelines, where patients have to meet their screening guidelines, so age appropriate, have to be uninsured or underinsured, and their income must be at or below 250% of the federal poverty level. And we put an easy table on our website to make it very quick and easy for providers and patient navigators to make that determination if the patient may qualify. Next, please. As you scroll a little bit further down on the page, it will show the big four, as we like to call it, the 4 different cancer screening modalities. We start with the breast and cervical cancer screenings. There's links here that go to our internal web pages at Huntsman that talk a little bit about what screening is, what it's like, what you can expect, why it's so important. But we also link out on all of these to our state cancer program that oversees the vouchers for the breast and cervical screenings. Next, please. And then right below that are our Huntsman specific voucher programs. So the colorectal cancer screening and then our lung cancer screening. And like I had mentioned, these are internal at Huntsman. We do perform these screenings at all of the University of Health clinics and community clinics that may have an endoscopy center or a CT center there. And we also have a link to our shared decision-making tool for primary care providers. Next, please. Oh, that seems out of place. One more, please. Oh, I think okay, thank you. So this shared decision-making tool, a large team of Huntsman's professionals who are doctors and also work in IT have worked with our EPIC program. We're one of those that run, it's the largest electronic health record system out there, and have gone in and created a shared decision-making tool that is required by CMS for reimbursement, but it also is just a click inside of the electronic health record. So the provider does not have to leave EPIC. They can go through the shared decision-making right there in office with the patient, and it's annotated for CMS requirements. And then it says, yes, we should screen. The risk may not outweigh the benefit. It'll come up with what's specific for that patient history with the PAC years, their age, their gender, and everything. But for those who don't have EPIC, we have screenlc.com. And this is exactly the same thing. It's just a standalone website. And we recommend it to all of the community providers to use this to document and to conduct their shared decision-making. It's a very simple, very well-tested tool that has been tested in conjunction with like the lung cancer screening roundtables with the American Cancer Society. The VA is using it, and Lung Cancer Society is also using it too. Next, please. And then at the bottom of our webpage, we have a space here for the providers that says, if you have questions, reach out. And then there are the 2 check boxes that you can click on. It brings up a simple form fillable 1-page order set for either the CT or the colonoscopy. And it can be filled out right there online and submitted, or it can be, a bunch of them can be downloaded, printed out, and then faxed in. But we're trying to make it as simple as possible for providers. And in about a year that we've had our program launched, we have had almost 50 patients referred from community clinics here in Utah, including like some of our homeless resource centers, federally qualified clinics, places that are seeing the patients that we need to reach. Next, please. So it's a multi-pronged effort that we are working on. There are dozens and dozens of people across Huntsman working on a whole bunch of different things, from chatbots to health record, EHR modifications, to voucher programs, to education for the community. And it's going to take us all working together, as well as things that we are looking at with this 5-state region that we're helping is, making sure that we're asking the correct questions every year on the behavioral risk factor survey that goes out, making sure our work is collaborative, and sharing our resources. Every one of these resources that I've mentioned and many, many more are available to you. And we are here to help you with anything that you may need. We know we can't do it. We know that you can't do it alone. It takes a collaborative effort from all of us. And we're just here to try to help you reach the patients where they're at. Next, please. Thank you so much.
Thank you so much, Lynette. That was a great presentation. And I feel like I need to just do a shout out to Lynette and Diane. SharePoint apparently is not our friend and we'll just do basic PowerPoint next time. You guys are awesome at just kind of going with the flow and adapting. So great presentations from both of you. You know, as we've kind of seen from these first two presentations, we know that low-dose CT scans and increasing access to cancer screenings are both really powerful tools when it comes to early detection. Screening and voucher programs, like Lynette talked about, are really essential when it comes to bringing preventative services directly to the communities. And so I'm so grateful for the work that she does. I would like to introduce our final presenter, Chris Kelly. Chris is the program manager for the University of Nevada, Reno Extension's Radon Education Program, which serves as Nevada's official radon department. In this role, she educates the public about the dangers of radon gas and conducts community outreach by collaborating with stakeholders to promote lung health and the importance of testing for radon during home inspections. Chris holds a bachelor's degree in business management and is a certified continuing education instructor in Nevada. She teaches the course, What Real Estate Professionals Need to Know About Radon, and is currently developing a radon education curriculum tailored for healthcare professionals. Chris, I would love to turn the time over to you.
Thank you. Thank you for the opportunity to share with what Nevada is doing for radon outreach. I get to do things a little bit different than the other states. And so I was asked to share some of the ideas and the way that I've been able to make some impact. Next slide. This is a video that was created and it just gives you the basic information about radon.
Jill, you'll have to hit optimize for video when you share to be able to get the sound. So if you unshare your screen and then reshare,
Okay, what's
it'll
that?
give you the option.
Thanks.
No worries.
Chris, I'm so sorry. It's not letting me
It's okay.
get the sound.
It's okay. I'll just tell you what it says. How's that? It just says that radon is an odorless radioactive gas. It doesn't matter where you live, that it's important to test. And it just talks about how radon causes lung cancer and how testing is really, really easy. So we can go to the next slide.
Sorry, one sec, technical difficulties.
Jill, if it's okay, I'm gonna go ahead and share my screen and just do the video from YouTube, if that's okay.
That would be
And then-
amazing. Yes, thank you.
Yep, and then you can get your slides squared away and I'll unshare and you can reshare.
Perfect, thank you.
Mhm.
We live in a beautiful state surrounded by picturesque mountains. But with mountains comes an increased risk of high radon levels. What is radon? It's an odorless, radioactive gas. You can't see it, taste it, or smell it. It comes from the ground and is naturally occurring, and it can make its way into your home through openings in the foundation. It's the #1 cause of lung cancer in non-smokers, so testing your home is important for you and your family's health. But don't worry, radon exposure in dwellings is preventable, and it's easy to test for. Testing only takes a few days, and results take a few weeks. Upon receiving your kit, follow the instructions, and then send the kit back. If your results are in the safe level, you'll want to retest every few years, since radon levels can fluctuate over time. If your results show unsafe levels of radon, you will need to fix it by hiring a professional.
Hello there.
No matter the age, condition, or location of your home, you can be at risk for radon exposure. The only way to know is to test. You cannot rely on your neighbor's results. Test your home so you can rest easy and share the information with family and friends. Visit our website for more information on where to pick up a test kit or to find professionals in your area to fix your radon problem.
I'll just go from here. I see some things on the slide that shouldn't be there, but I'll just keep going. So introduction to radon education. Radon is a radioactive gas that's naturally occurring in soil and rocks. And it is an odorless, colorless gas, and it's difficult, which actually is impossible, to detect without specialized equipment. And radon gas enters buildings, homes, any structure that touches the ground. It enters through foundation cracks in the walls or around plumbing and electrical, and it accumulates into dangerous levels. And as stated by the previous presenters, radon is the leading cause of lung cancer in non-smokers. And it's estimated that 21,000 people die per year from radon-induced lung cancer. Next slide. These are some more facts about radon. Lung cancer is the leading cause of death among women in the United States. And lung cancer kills more people than all other cancers combined. And every 25 minutes, radon-induced lung cancer claims another victim in our country. Next slide. There are some additional health consequences of radon exposure. The first is lung cancer. There are some more research studies that have just been released, and some of them are showing that there are neurodegenerative diseases that are being linked to radon exposure, and these are conditions like Parkinson's and Alzheimer's. Also, there are some studies that show a link between leukemia and lymphoma, and respiratory illnesses are affected by radon gas, so things like asthma and COPD. So next slide. So now I'm going to talk about the focus areas of the Nevada Radon Education Program. We have 3 focus areas. We provide radon education and materials to medical professionals. I also teach continuing education classes to realtors throughout the state. And I've been building a statewide radon resource network that I will explain on future slides. Next one. I want to talk about some of what I like to call the open door opportunities that have happened. And this is to just show that we never know what we're doing at that moment and how other doors will be opened and what other opportunities are available. So first of all, I want to tell you that by posting a children's activity page about radon on a college website led to an invitation to me being a guest speaker at a university, not my own university, another university. And so I was able to teach a physics class. And the instructor was getting permission for me to be a guest speaker. And when the dean found out I was coming, he wanted to attend the class. And now they are looking into including radon mitigation into their construction management course. And then another wonderful open door was I was speaking on a webinar through the Nevada Cancer Coalition, and Dr. Siobhan Haragal learned about radon from me, and she's now working on a mobile lung cancer screening van. So that's really exciting. Another opportunity was I was at a tabling event at a senior event, and I just happened to meet a hospice nurse, and we got to talking. And she also is on the board for future healthcare workers. And she asked me to be one of their speakers for one of their conferences in the spring. And then this last one, part of my job is to teach the employees at the extension offices in the rural communities about radon. And when I was teaching them, they were very, very good students. So then they tested their own buildings, and quite a few of those buildings came back with elevated radon levels. And so there was a lot of education for our college dean, for our OSHA safety officer, and opportunities for more people to learn about radon because they needed to mitigate those buildings. And then we just had this happen again on campus. So people at my university are finding out that they also need to test and mitigate the university buildings. So next slide. I want to give a shout out to the Nevada Cancer Coalition. Through collaborations with them, I've had many opportunities to collaborate with other like-minded stakeholders. I'm also included in the Nevada Cancer Plan, and there have been many wonderful opportunities with Larry the lungs and Lola the lungs, which are the large inflatable lungs. And people pay a lot of attention to the lungs, and seeing these big lungs really open the door for conversations. And then also I've been able to provide some educational material and presentations to medical professionals. Now, you might think, am I the best one to be doing that in the state of Nevada? Yes, I am, because radon information is not well known throughout our community and through our medical community. And they've been very receptive and thankful for the education. And I'm just really grateful that I can provide that information. There was a study done out of North Dakota a few years ago by Dr. Gary Schwartz. And that research showed that only 30% of family physicians knew that radon was radioactive, and that the younger the physician, the less they knew. So I think there's a disconnect in the medical school education. So we have doctors that, I mean, they don't know what they don't know. And so we get to help them learn more about radon and lung cancer. Next slide. So on the radon and the cancer control plan, the last 5 years, we reached our program goals for test kit distribution, for the use of the test kit, and for mitigations. And I'm currently working with the leaders on the next 5-year plan. And the Nevada Radon Education Program is the only program in Nevada that is addressing the dangers of radon gas. Next slide. One of the projects that I worked with the Nevada Cancer Coalition on was developing new maps. And I've added a QR code to the program that we made these maps with. And what it is this is an overlay map of radon levels throughout the state. It's broken down by counties, and then also the number of reported lung cancer cases, so that we can see the direct correlation between lung cancer and radon levels in the state of Nevada. This is the first time that these types of maps have been created. Next slide. Next slide. I spend a lot of my time teaching realtors through continuing education classes. And the way that I do that is I reach out to the offices and I let them know that they have 3 options to learn about radon gas. It's either a 20-minute brief, just an overview of radon gas, or a 1-hour general information class. But now I'm teaching a 3-hour, 3-credit class because the state of Nevada Real Estate Division asked me to provide a more in-depth class for the realtors. And I do a lot of marketing for that, which includes email blasts, leaving flyers at real estate offices, and just talking about it every chance I get. And then through these efforts, I've been invited through the Real Estate Association to teach at their buildings in Northern Nevada and in Southern Nevada. And since it's a 3-hour class, they will ask somebody to sponsor the class, and they'll bring in food and beverages so that I can teach the class. And we've had really good turnout at those events. Next slide. So a little bit more about the continuing education classes. The class was increased to 3 credits. So now that includes radon testing and radon mitigation. And the outreach that I do is not only distributing flyers to the real estate offices, I also contact mortgage companies, title companies, associations, and let them know that I'm offering a free class, and seeing if I can schedule that. And then there's the effectiveness of this approach has been great because Nevada is a non-regulatory state. So all of the testing and mitigation that's done is voluntary. And by doing this, just for the last couple of years, we now have 40% of our real estate transactions now include radon testing during inspections. And that's the only time that a lot of people learn about radon is when they're buying a home. Now, the biggest challenge that I encounter is that there are uneducated decision makers that think that real estate agents don't need to know about radon. And some of the things I hear are pretty wild. They'll say, well, there's radon everywhere, so we don't need to pay attention to it. Or they say, well, there's no radon, so we don't need to pay attention to it. So it's really, the field is really ripe for education. And then my big wish would be that we would be successful in changing the laws in Nevada so that radon testing would be required during all real estate transactions. Next slide. I want to share with how I built a statewide radon resource network. Most states run their radon program out of the health department, so there is a built-in network. Nevada, I work through the university, so we don't have that. So, but we do have an extension office in every single county. And so what I do is I go out and I train people that work in the extension offices on the basics of handing out radon test kits and just some basic radon education. So I use that train the trainer approach. I also do that same program at different businesses. So if you were to look at the map on the left-hand side, that is a Google map that people can go in. It's an interactive map and show where the closest radon resource center to them can be found. And so we have we have 30 throughout the state. And some of the businesses that I'm collaborating with are doctor's offices, veterinarian offices, a radio station, some realtor offices, just whoever is willing to have radon test kits. And it's actually been really fun to get to know people throughout the state and to create those partnerships. And then what I do is the second picture, I create a big box of supplies for them. And I call it an NRAM box because NRAM stands for National Radon Action Month, which is in January. So I give each county everything that they need to hand out. So there's test kits, there's maps for their county, there's fact sheets for their county. And then the last thing I want to talk about on building a resource is I don't know if you can see a picture of a lot of radon professionals, but what I did was I just cold called. I did a Google search for people that are already doing radon work or people that are HVAC or plumbers. And I just talked to them and I said, we really need more radon professionals throughout the state. Are you interested in learning about why this might be good for your business to add this into your business? And through doing that, we now have over 20 certified radon professionals in Northern Nevada. And I was able to increase the number of certified radon professionals in Southern Nevada by 500%. So what that means is there are now 5. So previously, there were 0 certified radon professionals in all of the Las Vegas area, which is crazy. But now we have 5, and I'm still working on getting more. Next slide, please. Some future projects that I'm working on is I would love to be a presenter for the Cancer Coalition's Lunch and Learn series. It's their CELL series. We are in the process of publishing the lung cancer and radon map overlays. We just started to be involved with the Pink and Pearl events at hospitals, which I think is a wonderful way to combine the information about breast cancer and lung cancer at those events. And then another project that I'm working on is adding radon information to the smoking quit line. And I'm working with the Cancer Coalition on that one also. And the next slide. I wanted to share some pictures of the activities that we've done. And through that, you can see that one of the activities was the Welcome to Las Vegas sign was turned pink for breast cancer awareness. So I was involved in that, and that gave me an opportunity to network with people that work in the breast cancer space and do some education about radon and lung cancer, and that has led to some collaborations. And then you can see the big Larry the Lungs. He's always really popular. And then you can see Mike from Genetech in one of the pictures because we all worked at a Pink and Pearl event together. And then again, working with the American Lung Association, that's always a good collaboration. And next slide. I wanted to share with you some research that was just released. And the conclusion of this research, it states, in the largest study of radon and childhood cancer in the US to date, we observed positive risk estimates for childhood leukemia in both sexes from average basement radon exposures the prior year. And the important part is the last couple of words in that sentence is that average radon levels are contributing to childhood leukemia, and the exposure was in the prior year. So we really need more research in this area because in previous research, we were taught that older people got lung cancer from, a long time exposure to high levels of radon gas, and we're finding out that that's just not the case. Next slide. So steps to take for collaborations. If you want exact steps, I'll be sharing these slides. For real estate continuing education classes, ask how to become a certified teacher. Contact the state real estate associations. ask to teach a class at their office, contact other businesses like mortgage companies, title companies, and cold call. It's great. And then working with the State Cancer Coalition, ask how you can get involved with outreach. Offer to teach a class about lung health. Offer to be on a committee. Ask if you can tag along to some of their events. Bring materials and network with other stakeholders. And for general outreach, doing online searches for events in your area is really easy. They can be found at eventbrite.com, at eventi.com, and also calling civic organizations, just cold call and ask them if you can be a guest speaker at one of their meetings. And then healthcare worker outreaches, start with who you know. Ask if there are speaking opportunities in person or online. Contact your schools for nursing, dental, and public health. Now, I want to share with you, I was creating this slide and I was literally typing the word nursing. And on the next slide, I'll show you the email that came in. I took a screenshot of it because I was so thrilled with it. So the next slide. So ask and you shall receive. I was literally typing nursing schools and I received this email from Bernadette Longo, who is a professor and works with the nursing schools. And in this email, she asked if I would collaborate. And she asked if I would write an article for one of their publications. She asked if I would be on the committee for the Lung Force Walk with the American Cancer and Association. And she asked me to do some other things. And I thought, you know, that's what it is. We just need to ask and just put ourselves out there and cold call and just say, I would love to be involved. How can I be involved? Next slide. I think we're going to take questions all at the end. So.
Yeah, thank you so much, Chris. I absolutely love how you ended your presentation with sort of those calls to action or what other states can sort of do. I know that the capacity of every state is different, right, depending on staffing and funding and all those things. But I think those are some really great takeaways for collaborations to explore if people haven't already. So thank you very much for your presentation. Hopefully all of these presentations as a whole have helped illustrate the importance of having a layered approach when it comes to cancer prevention and increasing access to resources and screenings. We are going to move into a Q&A portion of this meeting, but I actually would like, Jill, if you'll go to the next slide, folks to take this opportunity to use this QR code to take our evaluation while we transition into the Q&A portion, so that when the Q&A portion is done, you can leave and your evaluation's completed. This will help us inform future webinars. Please be kind for our tech issues, but we will keep working on those. Yeah, go ahead and get this pulled up. I'll give you just a second to do that. Okay. And before we go into my sort of guided questions, I think it would be great if we took an opportunity to see if there's any questions from folks here in our call right now. Feel free to unmute or put a question in the chat for any of our presenters. And if not, we'll sort of go into the guided discussion. I will ask our presenters to go ahead and turn on their cameras if they haven't already done so for this discussion portion. Okay, Well, let's go ahead and go to the next slide, Jill. We'll start with one of my first questions. And folks, as things come to your mind, feel free to chat in or use the raise your hand function or unmute. You know, I think all of you alluded to this in your presentations, that partnerships are extremely important, that this work would not happen if you were doing it alone. I think that was demonstrated very clearly. I would love to know, like, are there any strong partnerships that maybe you didn't have the opportunity to mention or that you want to elaborate on that have been crucial to expanding your program in your area?
We actually, in Nevada, received a grant from the Kentucky Leads program for quality. It's called QUILS, Quality in Lung Cancer Screening. So we can increase our lung cancer screening rates. That Lily can maybe elaborate on it if need to.
Yeah, that's awesome. Thank you for sharing.
And I would say that one of the biggest, especially for the voucher program, one of the biggest collaborations that and partnerships that has been beneficial for at least my efforts has been our primary care associations. And those primary care providers who, especially the ones that deal with those who are really low income, otherwise historically underserved, they really care about their patients and really want to get them the best treatment possible. And their buy-in to what we're trying to do to help them has been amazing. Their feedback, yeah, that's been a huge key for us.
And I think there have also been some unique partnerships across state lines recently. Lynette, do you want to share a little bit about that? I think that was, well, I'll let you talk about it.
Sure. Yeah. Not specifically focused on lung cancer, but we did have a lung cancer aspect to it. And for the first time ever, in Nevada and Utah, we both brought our resources for cancer education and screening to Windover, which for those of you who don't know where Windover, Utah is, there's this really fun little phenomenon that happens with Nevada that there's called border towns. And because of mostly gambling, they're located on the freeway systems. And this is the one that is on I-80, right on the Utah-Nevada line. So we parked our mobile mammography screening bus on the Utah side, and it was right next to the Nevadas. And so we had a bunch of women that came out to get their mammograms, but also Nevada brought their inflatable lungs. We had our inflatable colon, and there was a lot of education materials that went out. In fact, it was so successful that now the Windover Clinic wants to do it twice a year to have this big health fair. The community's still buzzing about it. So super excited about that and other partnerships where we can all just get together and reinforce the message that this matters so much, that look at all of these people who care about your health coming together to help you.
Thanks, Lynette, for letting me put you on the spot for that. I just think it's such a, it just demonstrates what a collaborator you are and our communities are. And I think it's a really awesome project. Okay, if there's no other thoughts, we can go ahead and go to the next question. So I think one thing that we always try to do in these calls is make sure that we find ways for other states to sort of take these ideas and either replicate them or adapt them. And so I'm wondering what steps or first steps, I guess, you would recommend that people start in their communities if they're interested in having a program similar to yours.
I honestly would recommend that they join their state cancer coalition. That is a super important place to start. There's a lot of resources that each of the state cancer coalitions have, and they work with their state departments of health or health and human services They all also work with us, and we're all very collaborative. We chat very, very frequently to help each other out. There is a safety net. There is a community out there, but start with your state cancer coalition would be my recommendation.
I'll just add that just talk to people, ask for those opportunities. I feel like I need to sell my program. And also, you know, I feel like conversation kind of went away during COVID and it's starting to come back. And so just talking to people, I've had some very interesting collaborations, like with teaching a physics class. I don't know anything about physics, but ChatGPT does, and I faked it. And it's leading to some really good things. So maybe my advice would be open your mouth and fake it.
Thanks, Chris. If I can too, you know, I really, like I said, I liked how you ended your presentation with collaborations that are possible. Many of the people here on this call are not actually in the radon space, but are in the cancer space. And so if somebody is working in cancer and wants to get involved in radon, who is the first person they should reach out to in their state? Person or group?
There's a couple of people on this call that I saw. I don't know if they're still on, but the Wyoming and Montana radon coordinators, both. Every state has a radon coordinator. Their level of work seems to vary. Some people are 10%, some are 50%. There's very few of us like myself that are 100%. But if you need help, ask me and I will help you find that person if their information is buried in some website.
Yeah, thanks, Chris. I think you highlighted exactly what I was hoping, which was just sort of the infrastructure that exists, that there are state positions for radon in all of our 5 states in our region. And you can get connected either through them or probably through your local cancer coalition as well. So thank you very much for that. And Jill, I think we have one more, or that might have been our last question. Thank you all so much for being here. I want to thank all of our presenters one more time for being on the call today, for all the work you put into your presentations, and for the flexibility and understanding to technical issues that always happen. So yes, I just want, if everybody wants to take a moment and give snaps, claps, whatever that looks like for you. Thank you so much for being here. We will be sending out the slides and the recording and our presenter contact information. So if you want to get in touch with any of them later, you are welcome to. But I hope you all have a great rest of your day, and we will see you next time.